Okay. Well, I want to welcome everybody to our inaugural session of the Rural Health Association of Utah's Rural Resource Webinar Series. This is a monthly series that will be held the first Thursday of each month and is designed to spotlight vital resources that healthcare professionals in rural Utah may not be aware of. Our goal is to improve the health outcomes and encourage greater utilization of these resources by creating meaningful connections between professionals and the supports that they need. After each of these sessions, the recording and resources will be provided through our website, www.rhau.org/RHAU-webinar-series, and RHAU is RHAU. As the series progresses, RHAU will build a robust library of resources that are accessible on demand by anybody serving in rural Utah. I want to take this opportunity to thank those of you who registered to attend today. Your participation is greatly appreciated, and we hope that you find this content helpful. And additionally, we would like to thank the Intermountain Health Foundation for the generous contribution, which is making this webinar series possible. Today's agenda, we're going to go through just real quick these housekeeping items, which we're already going through. And then we have two presenters for today's session. The first presenter will be Sarah Melville from mHealth Limited, who will be accompanied by Wilson. And then they're going to be presenting on the myCOPD app, which is an innovative app to COPD patients. And then the second session will be with University of Utah School of Dentistry. We'll hear from Dr. James Becker and Dr. Heidi Ingoli, who will talk about the U of U's Medicaid Associate Provider Program, as well as the Mobile Dental Outreach Clinic and other outreach efforts here in the rural areas in the state. And then I'm going to go ahead and introduce Sarah. Sarah will have about 20 minutes for her presentation, and then at the conclusion of that, we'll have a Q&A session. Sarah Melville has been a registered respiratory therapist since 2008. She obtained her associate's degree in respiratory care. Sorry, I keep bouncing back and forth between letting people in and reading. She received her degree in respiratory care from North Essex Community College. She also earned her bachelor's in science and healthcare management from Northeastern University in 2011, as well as her master's in healthcare administration from Southern New Hampshire University in 2016. And Sarah, fun fact, I graduated with one of my master's degrees from Southern New Hampshire the same year. So,
did you walk? Were we walking together?
I had the chance to walk, unfortunately.
Oh, all right. We would have been at the same thing.
I had
fun fact.
My first son was born. I didn't get a chance to travel out at that time, but Sarah has extensive experience in respiratory care, and she's a dedicated registered respiratory therapist specializing in chronic respiratory diseases over the course of her career. And she has developed expertise in improving patient outcomes through the creation of effective workflows and care pathways, as well as advocating for better pulmonary rehab practices. Sarah is a digital respiratory specialist focused on integrating digital health solutions into respiratory care. She supports healthcare providers and patients in adopting remote therapeutic monitoring to enhance patient outcomes and streamline pulmonary care. By leveraging digital tools, Sarah helps improve both patient engagement and care delivery in pulmonary health. As an adjunct professor at the Massachusetts College of Pharmacy and Health Sciences, Sarah is passionate about bringing clinical practices and academic learning, providing future healthcare professionals with valuable insights into the world of respiratory care. In addition to her clinical experience, Sarah is deeply committed to innovating healthcare administration, working to ensure the delivery of top-tier patient care. She has made significant contributions in the field of pulmonary rehabilitation, focusing on improving patient outcomes, reducing hospital admissions, and enhancing the education and support available to those living with chronic respiratory conditions. Sarah's dedication to advancing healthcare and fostering the new generation of healthcare professionals makes her a valued voice in the ongoing evolution of pulmonary rehabilitation. Sarah, the time is yours, and we'll go until 12:25.
Okay, great. Thank you so much for having us. So basically, I just wanted to kind of introduce what I've been working on the last 9 years of my respiratory career has been in pulmonary rehab. So I've become super passionate about that population. And as we know, there's not nearly enough pulmonary rehabs in person to manage the 24 million COPD patients that are in this country. So when my pulmonary rehab was shut down, I looked at other avenues as to how we can help this patient population. And that's how I was turned on to mHealth's myCOPD product. So I'm just going to talk a little bit about that. And then I have a couple slides. And then at the end of my slides, my colleague is going to actually show you guys a demo about how it actually works real quick, and then we can take some questions. So Casey, next slide whenever you're ready. So basically my COPD is an on-demand COPD care solution. It's a self-management application to help patients become more engaged in their treatment, be able to manage their symptoms at home, basically teaching them to really become the experts of their disease process. It has the largest body of evidence that supports how well it works, and I'll talk about that on the coming slides. But what I really liked about it from an RT perspective is that it really was engaging for the patients to be able to do what they needed to do at home if they couldn't be given the access to face-to-face pulmonary rehab, which is the problems that we're running into in the healthcare systems today. Their programs are being shut down because they're not reimbursable. They have transportation issues. There's low referral services and things like that. So next slide, Casey. Oh, keep going. So inside the app, the patient and you'll be able to see when Ian does a mini demo, is when the first thing they do when they log on, it's going to ask them to kind of log their symptoms. How are you feeling today? How's your shortness of breath? How's your cough? How's chest tightness? Basically how we would assess our patients if they were coming in face to face. And given their response to those questions is going to kind of prompt what they need to do. So there's all sorts of things that are super useful for them. There's inhaler training technique, self-management. There's lots of education. There's an activity diary, because the most important thing we teach patients in pulmonary rehab is you need to keep moving. We recommend 2 to 3 times a week minimum. Ideally, we want them doing 150 minutes a week of moderate exercise. That's in a perfect world. These patients tend to not be the perfect population and need a lot of prompting and engagement, which is why a tool like this is really good, because it will offer weather, air quality, the pulmonary rehab videos on demand, a medication diary, so it can prompt them to take their inhalers. They're able to put in their short acting, their long acting, things like that. So things that we would be doing at an in-person level is being able to be done for the patient at their home. And this can be used either on their smartphone, anything that connects to an internet, they're able to use it at. So next slide. So these are the 3 studies that really kind of proved that using an app is really just as comparable as being in person. So the first study is the online versus the conventional. And what that was is that was a 6-week program, and it basically showed that there was no inferiority from a patient doing a 6-week face-to-face versus the virtual. So the patients each did a 6-minute walk at the beginning and at the end, and they and then we did the symptom scores, and they were comparable. So there was no inferiority to the patient who was doing the virtual on-demand pulmonary rehab versus the face-to-face, which was great. Because, in rural areas, there's problems where patients live 3 to 4, 1 to 2 hours away from coming in for pulmonary rehab. Even where I'm in Massachusetts, we have patients that don't even want to travel like 30 to 45 minutes to go to pulmonary rehab twice a week, because when they're in that age group, it can be a challenge. The second study is showing the effectiveness of myCOPD versus the standard usual care of what you're doing. So patients that would have an exacerbation, what would they normally be? They would be following up with their primary care. They would be ordered on inhalers. And so some of the patients were done with the regular pathway, and other patients were placed on the myCOPD. And the myCOPD, those patients who recently had the exacerbation had improvement in CAT scores and improvement on their inhaler techniques. So again, showing that patients that have recent exacerbations that can be placed on a digital therapeutic, it was helpful as opposed to using the regular way that we would be managing these patients. And then lastly, the early study, is basically patients that were newly diagnosed or had mild COPD. It was proven that they would also benefit from using a digital therapeutic, even though they had mild or they were new diagnosed, because it helped improve their CAT score, which is the COPD assessment test. Using the app, they were still using it after a month of being on it. So it helped improve symptoms, helped reduce sick visits, even though they were new diagnosed or had mild symptoms. Next slide. So why are we able to be over here and promote this? So this, myCOPD has been in the UK, and Ian will probably explain this way better than I will, for the last 10 years. And they have been promoting it and using it for their COPD patients over there. So why are we branching into the US? So remote therapeutic monitoring codes. So all these services that we're not being compensated for in pulmonary rehab, like education, inhaler teaching, pursed lip breathing, diaphragmatic breathing, and exercise. It's all bundled charges here. So you're not being able to get reimbursed for any of these services. So they're uncompensated. So now what are we doing? So now there's 4 codes that are able to be billed for having these patients use a digital therapeutic in conjunction or without a normal pulmonary rehab program. So I'll just touch lightly on these, but the first one would be 9895. And basically that would be the code that gets unlocked when we set up a patient and they are activating on the account. And so they're using the equipment, which is the app. And then the next code would be, we want them to engage 16 out of the 30 days in the month. So we would say a minimum of 4 times a week, we want you to log in your symptoms, do activity, do a pulmonary rehab video, like all these things that are engage and help with your symptoms. And then lastly, the communication codes. So when patients are having issues with their COPD, they're going in, they're seeing their physicians more frequently, they're doing telehealth visits, things like that. And this would be the communication code. So for 20 minutes for the first, in the calendar month, the first 20 minutes become a billable act. So if you're doing like a weekly or bi-weekly telephone call, that's all can be documented and charged, so you can get reimbursed for that. And then the last code, the 98981, anything additional over that 20 minutes that you're doing, again, is more reimbursable activity that can be done. So I know I kind of roughly touched on that. Ian will probably touch on it a little bit more, but we can also provide some more documentation to go over that in more detail, as we are limited for time today. Next. And this is just our disclaimer. I'm not going to read that. So do you want me to do, so we can do questions after the demo, right,
Yeah.
Casey?
Yeah,
Okay.
I think questions after will be good.
Okay. So Ian is my colleague in England, and he'll probably do a much better job than I just fumbled through that. So he's going to do like a mini demo, kind of give you guys what it would look like for the patient. He's been in the digital health space for the last 10 years. He's one of the co-founding shareholders. Played professional soccer over in Florida for college. It's a fun fact. Used to, and yeah, anything else I'm missing?
No, all good, all good. So, guys, I am a US academic alumni from went to university in Florida. I think we ended up having spring break for about 4 weeks by the time everybody has spring break over the country and descends. So, the spring break season was always long and painful. But anyway, look, it's really good to meet you guys. Sarah's obviously given you kind of a bit of a a nutshell of what this is all about. But if you're dealing with COPD patients, ultimately, what we're trying to do is just change the way that patients can get access to services, and it doesn't always have to be face to face. Healthcare has been a very, very, very slow adopter of using digital to actually enhance its outreach of what's going on. So, what I'm going to be showing you today from my COPD's perspective is what we would call digital therapeutic. Okay, this is a digital intervention that can be prescribed essentially by the clinical team, and it will have a clinical outcome. It will teach patients how to use their inhalers properly. It will give them instant access to on-demand pulmonary rehab. And we've come to recognize that in the US, you talk a lot about virtual things. So like virtual rehab, it's not virtual rehab. It's not Sarah live delivering me a session. It isn't that. This is an on-demand program. And everything we talk about, there's randomized controlled trial evidence to demonstrate its clinical effectiveness as well. So, I know Sarah kind of touched on some of the clinical outcomes on that, but I think it's super important you kind of understand that this tool now that we've been using in the UK for nearly a decade now, we've obviously changed it. Our caveman version back in 2016 is completely different to the version that that you'll see today. And what we've done is we've streamlined how the program works to fit alongside those RTM codes that Sarah was talking about there. So that essentially the therapeutic can now start to generate some money through that digital channel as well. So I'm going to share my screen with you guys, and I'm conscious I have probably about 9 minutes to give you a bit of a whistle stop tour over the program. I think I'm sharing my screen. So Casey, are you able to give me a nod?
Yes, we see your screen.
Brilliant. Okay, so as Sarah was kind of mentioning, so myCOPD is an online tool. Okay, so it works on anything that connects to the internet. Okay, so any patient that has internet access, whether that be on their smartphone, their tablet, their desktop computer, laptop, anything like that, they would be able to access myCOPD. Okay, and this is something your patient cannot just go and download. Okay, this is a program that the clinical teams need to essentially give access to the patient, so they're able to obviously go in and see those things. Okay, so what we've essentially done is we've taken everything that the COPD, like a patient who's been diagnosed with COPD, whether they've been discharged from hospital, whether they're newly diagnosed, in the primary care setting, everything they could possibly need is put into one place. Because the reality is that when patients are diagnosed with a condition they haven't heard of, they're just going to go outside the consultation room, get in their car, get their phone out of their pocket and Google it. That's the reality. We still in healthcare give booklets and leaflets and things like that, and especially in COPD as well. So what we've got here is a resource that not only will help patients manage their condition beyond the four walls of that consultation, but there's also an opportunity there for the service to utilize the RTM billing element as patients start going through and using things. So if we take a little bit of a kind of a visual tour of what's available on here. So we have an on-demand program, a pulmonary rehab program. Okay, there'll be lots of patients, if you deal with COPD patients, that are unable to make it to their COPD classes, for their pulmonary rehab classes for whatever reason. Okay, we have an individualized program that sits within this so that patients are able to access it. Okay, we have a COPD checklist in there. So what this does is, if I go into this, it provides the patients with a bit of insight into what they need to do to be as well as possible. And most of these things in here are activities that fulfill the RTM billing requirements. And if there's things in here that they haven't seen or done before, so let's say this inhaler video section was red, I could click in that and it takes me straight through to my medicines. And these instructions are 100% correct 100% of the time. There's no variation. I'm not going to go and see Sarah as an RT and Casey, who is my pharmacist, and then show me two completely different ways of using my inhaler. These things are correct every single time, and we have the clinical evidence to demonstrate that as well. Anything that happens in the program is changed in itself. So let's say if we go down to the self-management plan, so every patient is required to have a digital self-management plan. The clinical team don't add anything in here. They don't add the medicines in or anything like that. The system does that automatically when the patients are given access and they start going through the onboarding thing. So if for argument's sake, I have a different inhaler that's been changed, I'm just going to change my inhaler in here, and I'm going to add in my new one. Okay, so my clinician has prescribed my new inhaler. I'm just going to prescribe myself Embryo. Okay, obviously the patient can't self-prescribe in here, but they can add this medicine into their program. What you'll see is through the whole system is that if we went into the self-management plan, which I've just been in and shown you, the new medicine is added. So this is telling the patient that regardless of how you feel, this is a medicine that you have to take every day, regardless of how you're feeling. If you're feeling well, you take it. If you're obviously having a severe deterioration, you still take it. It's a maintenance drug that you need to continue to take. But instantly, again, that inhaler has gone into the area of where the patient would learn how to use their inhalers as well. So all they'd need to go, and again, this is that on-demand element. The patient can come in here 24 hours a day, 7 days a week, click on a video. I'm just going to press pause and I'm going to mute it because I don't want to interrupt in our internet bandwidth here. And they're going to be able to see how to take this inhaler. It's an 80-second long video for this particular inhaler, and the nurse on here will take them through step by step on how they need to use it. We have a number of other things on here. Okay, so we've partnered with the COPD Foundation. This is their kind of social networking area for patients with COPD to network with others. So again, as being part of a rural community, I can imagine, you know, some COPD patients won't necessarily be able to get out that much, but we've made sure that we've kind of partnered with one of the leading charities around those things. We also have a ton of education in here. So, and it's all expert led. So if I went into the educational course as an example, again, there's a video component. There is a reading section. There's a ton of education about what COPD is, how you deal with breathlessness, things that patients might be super uncomfortable about talking about, like sex and breathlessness. You know, they might feel really uncomfortable about talking about those things. So all of that's available for the patients. And don't forget, all of this would normally be taught in the confines of a consultation with the clinical team. So really we've tried to capture all the different things that patients need, like a COPD assessment test. This is a clinical test. Anyone familiar with COPD will know what the CAT test is, and patients are asked to take these things. But we've turned it on its head slightly because we ask the patient to take their CAT test, and I'm going to do it super quick now. So there's 8 questions. I'm just working through them now. And what will happen is it will feed back to the patient. Well, your CAT score is 20. Based on that and based on your activity, have you thought about starting your pulmonary rehab, going and watching your new inhaler video, things like that? So it manages their self-management so that the clinical teams don't have to keep doing it. And like I've pointed out, a lot of the things that I'm literally doing a bit of a whistle-stop tour over are billable pieces. If the patient goes in and watches their inhaler, that goes against the activity that they need to complete as part of the billing process. Even coming in and looking at the air quality, I haven't got the air quality working. I said it couldn't access my location, so apologies about that. But even going into the air quality or the weather forecast, all those different things, it gives the patient a bit more understanding as to what's actually affecting them in their environment and things like that. So we've got last couple of things as well. We've got a mindfulness section. A lot of patients with COPD can become really anxious about their breathlessness, things like that. So it's really important that we give them the techniques, the area to kind of start to understand how to manage that anxiety if they do start to become a little bit panicky when they do get a little breathless, which is going to happen. And again, you know, you can't walk into a primary care practice and get access to all of these things because, you know, that time with the medical team is already set on what needs happening. But actually what you can do is when the patient leaves that environment, they can actually leave on myCOPD with a very clear expectation of what they can go and do. And that is not only going to improve their outcomes when it comes to their COPD management, but it also could actually open up a different revenue stream for the clinical services as well. So I've tried to be really quick and keep to time, and I think I'm 10 seconds off the 5-minute window for questions. So I'm going to stop sharing my screen, and I'm going to ask if anyone's got any questions. Feel free to unmute and ask away. Stunned silence is always a good thing.
I've got a question, Ian. What is the steps for a provider to start working with this program?
Yeah.
Set up a clinical account first?
Absolutely. So what I haven't shown you, and we haven't had the time here, Casey, is there's a whole administration portal which captures everything the patient is doing in there, so that not only is it going to streamline the billing activity, but also it's going to allow those clinical teams to actually onboard patients. So Casey, it would be a case of you having access to the administration portal when you saw a respiratory patient, a COPD patient, instead of giving them, the paper-based self-management programs, things like that. If they have that internet access, if they do online banking, online shopping, it would then be the job of the administrator or the administrative team, the clinician, to onboard the patient then, like there and then, so they can leave the consultation with access to the program itself. And you can see what the patient's doing in terms of whether they're accessing their inhaler videos, their pulmonary rehab, their education, all these different things. It gives you a bit of an insight into what they're doing to manage their condition.
And how does the clinic set up their side to be able to enroll patients?
Sarah, do you want to kind of answer that question? I feel your RT.
So you mean like how do they set it up?
I have a provider that wants to start using your myCOPD app. I assume they set up an account for their practice first, and then add access for their patients. How do they set up their practice account?
So they would enroll in the software, and then the software would be whoever would be seeing. Usually it's a nurse practitioner, a provider, and when they're seeing those patients, they would be, because all you need to enroll is an email address, a date of birth, and the name, and then that email gets sent to the patient. And if they have their smartphone on with them, a lot of our providers are just having them do it right there with them, because it takes about 90 seconds to set that patient up once they get that email. And then once they're registered, they can go with it. And they can log their symptoms. They can do everything like that. Is that what you mean? Like how they're putting it into their pathways?
So. Yeah.
Okay.
Yeah.
It's office specific, really, where it can fit in. One primary care has a champion NP that she does it with her patients right now to start. And then we have a pulmonology practice that is having multiple providers and an operations director that is also assisting with onboarding. So it really depends what fits best within their practice pathway.
Awesome. Any other questions for Sarah and Ian? Are there components of the app that can be accessed without Wi-Fi or network access?
Good question. And the short answer is no. So it's a web-based program that would need the internet to access. There are some elements of the app as such, if you had it on your smartphone, that you would be able to, but I don't know all of those things off the top of my head. It's not a question I've actually got asked very much in 10 years of doing this. So yeah, I don't actually know the full answer of that, but essentially it's a web-based program, so it needs the internet to work properly. Okay. Thank you for the question, though.
Any other questions? I do want to provide Sarah's email in case you want to reach out to Sarah. It's sarah.melville, which is MELVILLE at mHealth, all one word, .com. If you have a hard time reaching, yeah, please do. But just wanted to read it for the recording. And then if anybody's having a hard time accessing Sarah, getting the right email, feel free to email info@rhau.org and we can connect you as well. So thank you, Sarah. And thank you, Sarah and Ian, for your presentation. We really appreciate it.
No worries. Thank you very much.
Thank you so much for having us.
Yes, absolutely.
Thank you.
We'll switch over to our next presenter. So we will have Dr. Becker and Dr. Yongi, who are presenting during the presentation. I'm going to introduce both of them, and then I'll switch over and let Dr. Becker take over. And Dr. Becker, just let me know when you want the slides advanced. Dr. Becker is a pediatric dentist with extensive experience in both urban and rural private practice. He has held key leadership roles, including clinical and medical director of a pediatric dental graduate program at Primary Children's Hospital and associate dean of clinical affairs at the University of Utah School of Dentistry. Currently is an associate dean for professionals, community, and strategic relations. He oversees the UUSOD Associate Provider Network for Medicaid, advocating for innovative Medicaid programs at both state and national levels. He's also played a significant role in organizing dental hygiene collaborations and leading clinical trials focused on pediatric dentistry. And then followed by Dr. Becker, we will transition to Dr. Yongi. I'm still saying that right, Heidi? Yongi. So Dr. Yongi is the Director of Community Engagement and Clinical Integrations at the University of Utah School of Dentistry. In this role, Dr. Yongi leads the UUSOD's community engagement efforts aimed at improving the oral health of all Utahns by improving both access to care and oral health literacy. She also works with colleagues across the UHealth to integrate oral health into the broader healthcare system to improve the outcomes of patients and the patient experiences. She began the Master's of Science in Clinical Investigation in 2024 to increase her knowledge of performing clinical research aimed at improving both oral health access and outcomes in areas of oral health integration and public health dentistry. Dr. Becker and Dr. Yongi, the floor is yours until 12:50.
Great, thank you. I'm going to talk fast. At the dental school, we started with a couple things in mind. One was to serve the underserved in the state of Utah and to teach excellent oral health professionals that are integrated with primary care, because we have extensive studies that show when you improve oral health, general health improves, and healthcare costs go down. So with that, we're just going to talk a little bit about, in Utah, access to oral health care for Medicaid patients. In 2008, the state of Utah discontinued all dental benefits for Medicaid eligible patients because of money. And when we created the School of Dentistry, we found a pathway where we could access federal funding and start to provide oral care for certain groups. We started gradually. Go ahead with the next slide. We started with blind and disabled population. Then we added targeted adult Medicaid, which was substance abuse disorder patients that were in rehab programs. And then we added the elderly population, 65 and above. So that was about 70,000 patients around the state that began to have access to oral health care. Next slide. In order to access this funding, two things needed to happen. One was all the oral health care needed to be provided by a state entity. Well, the University of Utah School of Dentistry is the only state entity in the state that does dental care. The other requirement was that the seed money into the federal program needed to be paid, and the state was not willing to do that. So the University of Utah School of Dentistry, with our endowment, was positioned in a place where we could, and we stepped forward and said, we will pay the seed money into this program. So a state entity pays the seed money into the program, accessing the funds. Next slide. That created this, for 70,000 patients around the state of Utah, that was a little bit of a problem, because our clinic and we have 9 other clinics around the state where our students rotate. We couldn't possibly see all of those patients. So what we did, we worked on creating what's called an associated provider agreement. And that is such that any dentist in the state of Utah can sign that agreement and become associated with the School of Dentistry in such a way that they become a state entity in their own office, in their own community, throughout the state. And next slide. We currently have over 400 associated provider dentists throughout the state who, through this agreement with the School of Dentistry, are able to treat Medicaid patients in their own offices, in their own communities. One of the things that was always a negative about Medicaid was the reimbursement to the providers was low. And with this program, we have been able to add procedures that weren't previously covered, and we have been able to increase the compensation rates. So now compensation is in the same ballpark with the top 5 insurance programs that most dentists use in their offices. So it's a win-win. The dentists are really excited about doing this because they are getting reimbursed and they can meet the needs of the underserved in their own communities. Next slide. With those 3 groups, that has gone so well that the legislature passed a bill and CMS signed a waiver that was signed on January 13th, 2025. And on April 1st, this dental benefit to Medicaid patients expands to all adults in the state. So any adult throughout the state that has Medicaid now has full dental benefits. And those benefits, there's no limit to what can be done. There's no copay by the patient. The bills, the reimbursement requests are submitted straight to Medicaid, and they are reimbursed straight back to the doctor's offices within 2 to 3 weeks. So again, a win-win situation. When this expands on April 1st, that'll be about 220,000 patients around the state of Utah that will have access to oral health care. Next slide. One of the things that has come about because of this is this wonderful database that we now have with Medicaid of all of these patients around the state. And we can track, because we have an integrated medical record, EPIC, with Medicaid and all the patients' healthcare records, we can track different associated morbidities that are improved when oral health care is improved, so that the research opportunity has just exploded. And we're able to do quite a bit now to show that as we increase and address oral health, general health improves, specifically in the areas of diabetic patients and heart disease. Next slide. In addition to these associated providers around the state, we have our mobile van, and Dr. Iongi is going to talk about that in just a minute because it's amazing and meeting another need that we have. Next slide. We also have our oral health assistance program, which is an endowment at the school that provides funding for patients who don't have any avenue of care, no funding of their own, no insurance, and cannot qualify for Medicaid. They can apply for funds from Oral Health Assistant Program, and their care is paid for as they qualify. So Utah is leading out across the country in providing care for underserved populations throughout the state. The key has been that we partnered with the Utah Dental Association in recruiting all of these dentists around the state to be a part of our program and provide the care. Great for patients, great for the providers, and we're meeting the needs. So with that, I'll turn it over to Dr. Iongi, and then afterwards we can answer questions. This is a slide if you just want to take a picture of that. That's the email for our team at the School of Dentistry that handles this program. And also the website that you can go to. Dr. Iongi.
Thank you. Do we have our next slides up, Casey? I guess we'll do it at the end. Okay, thank you. So for my intro, I am our Director of Community Engagement. So I'm going to talk a little bit more today about our mobile dental clinic and the areas that it serves, some of our other community engagements, and how we can partner with our rural communities. So Dr. Becker touched on this, but I always like to orient our slides, and it got a little bit cut off there. But our mission is really to advance health by service, education, and research. And it just helps in understanding why we do what we do, that service is core to our mission and caring for underserved, educating dentists that are passionate about this as well. And as Dr. Becker mentioned, we do know that this advances overall health and influences healthcare policy, as we've already done with our associated provider program. And we can go next slide. So that's just the outline, and we can go ahead and move one more. Sorry, there's too many filler slides here. Thank you. So our mobile dental clinic. So this is a program that initially was ran by the state, and then when the state closed all of their family dental plan locations, fortunately, the School of Dentistry was able to come in and take over those programs so that the patients that were receiving care in those clinics and also from the mobile dental clinic could continue to receive care. So we've done this program since 2021, and this is funded from the State of Utah Primary Care Grant, which we're very grateful for. So our van, I always like to show here because it's a little bit of a misnomer. We don't actually do treatment in the van. It's more of a transport, and we do rely heavily on our community partners, mainly the health departments in each location, to help us set up a location where we can then set up all of our mobile equipment. But it's helpful for us in being very flexible in where we go. We can go next slide. So again, it was created to improve access to care. We're always looking to expand our associated provider program, but we knew there is historically been areas where we don't have associated providers, where access to dental is very low. And those are the areas that we really try and bring the van to and increase access to care. Students do go on rotation with us, and we find it's a very meaningful experience for them in hopefully increasing their desire to serve these communities after graduation. So, and I apologize, I should have updated this for this last year, but for our fiscal year 2023, we saw 424 patients. We had 424 patient visits during that year, and we are funded by, as I mentioned, by the primary care grant. And so we can go on one more. So who do we serve? So we see individuals with no dental insurance. There is a vetting process for the patients that we see. So we do verify that they don't have any dental insurance, that they're not eligible for these Medicaid dental benefits. And then we also do vet income. This is self-reported. They'll report their income. And so we see individuals that are 200% and below of federal poverty that are either uninsured or underinsured. And so we typically see about anywhere from 20 to 30 patients in each location, and each patient gets an initial visit and at minimum one follow-up visit so that we can take care of as many of their dental needs as we can during the week that we're there. You can go to the next one. So during our mobile visits, we do a little bit of everything. We do preventative care, we do fillings and basic restorative, we do emergency care such as extractions, and sometimes starting a root canal. And then we arrange for ongoing care. And this is really the piece that's really important to us, and where we're very grateful to have our associated provider network, is that we try and communicate with associated providers that are in the area and arrange for ongoing care for the patient to improve their access. So this is kind of an example of where we go. This is where we have went this fiscal year. And so we typically go to 9 locations over the course of a year, and we spend a week in each location. These sites are selected based off health professional shortage area scores. Those HPSA scores are used to guide our decisions, as well as our relationships with the partners in the area. They do shift slightly year to year, and we don't have our sites typically until we receive our grant funding, which typically happens in July. So I don't have sites right now for past June, but Casey's been wonderful to get all of our sites up on his website. So as soon as we do have other sites, those will be listed there, as well as on our website soon as well. So you can be in touch with us for where we'll be. So as I mentioned, we do coordinate with local health departments to help find patients. So for each site, there's usually a couple different ways that you can schedule. And so that's why I just have our contact information included here. But for site specific, there would be scheduling information at the local health department as well. But you're also always welcome to reach out to our dental outreach email for scheduling for patients or for questions about the mobile dental clinic. So next, I'll go over just briefly some of the other community engagement work that we do. So this is a little bit more focused across the Wasatch Front, but we are always actively looking for ways that we can improve and include rural areas as well. So we attend a lot of health fairs, community events. We partner with local health centers, churches, schools to just try and improve access to care. And so if we can go one more. So at these events, we do preventative care typically. So yeah, Steelman's, Profi's, Fluorizet, you're fine to go ahead. We don't typically do treatment at these events. So in the past year, we did do about 686 dental screenings on a lot of preventative services as well, and we attended over 28 events. And like I said, sometimes our resources are limited, but I always welcome hearing from different community members about health fairs that you may have or ways that you want to involve our mobile dental clinic, and we are always trying to grow. And so if we have the ability to partner with you, we are happy to do that. And that's basically what I said. The dental outreach email is the best way to get in touch with us for any outreach or also for our mobile dental clinic. So I'm happy to take questions for, and I think Dr. Becker's still on as well for either of our programs.
There is one other thing that I didn't mention, just for those of you that are wondering. There is a section of patients, pediatric and pregnant women, that are still covered through Medicaid, but under managed care companies, which is different than what we're doing. And this legislative session that is currently happening, the fiscal analysis people looked at moving away from the managed care companies and including pediatrics and pregnant women in this program that we're doing at the U, and found that it would save the state $20 million each year. And so they did a shift in appropriations and will be moving away from the managed care companies in 2026. So the target date right now is July 1st, 2026, which will then have pediatric patients and pregnant women also covered through the associated providers and the U of U dental clinic program.
Dr. Yangi, for providers that are wanting to send patients to your dental clinic, is there a process to set up an appointment, or is it walk-ins during the week that they're there?
A little bit of both. So we do, typically the way the mobile trips go is the first 2 days we're doing all exams for patients, kind of getting their treatment plan set. And then the rest of the week we do treatment. So yeah, in advance of the event, you can either email us and then we can get you the right health department contacts, because since they usually do the initial scheduling for us, because again, it is site specific.
Mm-hmm.
So if it's kind of in advance of the event, we can get an appointment scheduled that way. But typically during the week, we are able to accommodate walk-ins, and we really try our best to do that. So if someone didn't get an appointment, but you see that we're in your community that week and something comes up, please send them our way and we'll do our best to accommodate them.
Excellent. And they'll be in Kanab just next week if anybody's got patients down that way. So
Yes, thank you. Thank
Mhm.
you for that.
yeah. Do you have any other questions from the group?
We appreciate you letting us join you today.
Absolutely. And then Anna just added in the chat, if you want to set up an appointment, you can call 801. Oh, sorry. I don't know if they see the chat in the recording. So I want to read this number, 801-646-6231. And you can make an appointment by calling that number. And thank you, Dr. Becker and Dr. Iongi and your whole team for participating this week and for everything that you're doing. These are all really great programs. I was happy to have you guys as one of our presenters because you highlighted a number of different resources that would be beneficial to providers and to the general public. So thank you.
Thank you for having us.
Yeah. Just in closing, thank you again to everybody who attended the session today. Your attendance and participation is critical to the long-term success of this series. So thank you so much. Our next session will take place on Thursday, April 3rd at 12 p.m. We will have a presentation on suicide prevention resources and data from the University of Utah. Sorry, from the Utah Department of Health and Human Services from the Division of Substance Use and Mental Health. We will also be welcoming Angel Flight West, who is a nonprofit organization with a network of over 1,800 volunteer pilots who fly individuals and families on their own planes at their own expense to help make sure that they have access to critical healthcare resources. You can RSVP for that resource using the QR code to the right on the screen, or by visiting our website, www.rhau.org/RHAU-webinar-series. Additionally, the recordings from today's session will also be made available on that website. We are currently accepting applications as well for future presenters. So if you and your organization have content or resources you would like to present in this series, you can also find the link to submit a application to present in a future series or a future session on the website as well. And once again, thank you everybody for attending today. We hope you have a wonderful day and we'll see you all in April.